minutes to few seconds to start the recording. All right. Welcome, everyone. Thanks for joining us for the May 2016 NHSN CDA vendor webinar. I'm Mindy Durrance and will be presenting along with my colleagues Dr. Dan Pollock, Dr. Barry Rhodes, and Amy Webb. As a reminder, please make sure to mute your phones. We will take all questions at the end of the presentation. The recording of today's webinar will be posted on the NHSN website on the CDA submission support portal. We have a lot of information to present today, so Dr. Pollock, please start us off.
Thank you, Mindy. So glad to be with all of you. I want to begin by talking about the upcoming APIC annual conference in Charlotte, North Carolina, Association of Professionals in Infection Control and Epidemiology. We will, as in past years, have several opportunities to interact with you at the conference and before the conference. In the pre-conference session, we're having, although it requires pre-registration and some additional cost, NHSN SSI, surgical site infection, and multi-drug resistant organism, Clostridium difficile infection surveillance and data analysis on Friday. A major event is the NHSN members meeting on Sunday afternoon from 4:15 to 5:45, although predominantly oriented towards the infection preventionists and providing updates on NHSN. In past years, we think that this session has also been valuable to your companies, and if you have an opportunity to be represented at the meeting, there will be important information that I think will be of benefit. There are NHSN educational sessions as well, Saturday, Sunday, and Monday. I know Amy is going to be doing an antimicrobial use, antimicrobial resistance session on Monday, for example. And then, importantly for everyone on the call, our information technology group will be meeting with vendor companies one-on-one on Friday and Saturday. We do have some availability yet on Friday, so please let us know by sending an email to the address listed here if your company has not already booked time and you're interested in one of those 2 Friday slots. So next, I wanted to update you on the fact that the Centers for Medicare and Medicaid Services, CMS, recently in late April included possible inclusion of the NHSN antimicrobial use measure in a future iteration of CMS's inpatient quality reporting program. For those of you who are not familiar with the Inpatient Quality Reporting Program, it is the program that has incentivized the reporting of SSIs, catheter-associated urinary tract infections, central line-associated bloodstream infections, C. difficile, MRSA bacteremia, and some other NHSN events for purposes of public reporting and tying those events to payment. So CMS has signaled with this request for comment an interest in eventually, I want to emphasize that, using the antimicrobial use measure that we have developed at CDC that was endorsed by the National Quality Forum earlier this year in the IQR program. And if you're interested in the explanation and the rationale for CMS's proposal and some additional background information, you can go to the Federal Register announcement, and listed on this slide are the pages of that announcement in that notice, and also the pages in terms of the PDF version if you do the link to the PDF version. Note, please, that comments are due to CMS by June 17th. Next slide. An update on our NHSN release schedule. We have moved to 1 major release a year, so the changes in our our protocol, the changes in the application. Really, we're making a concerted, very complete effort to have those changes introduced once a year in the January, late December or January release of the NHSN application. And as the slide indicates, this release of NHSN will include the protocol changes and new CDA versions that follow from those protocol changes. Now, although we do want to remain committed to this once-a-year major release, we recognize that from time to time we will have to apply service packs to the NHSN application, and these could include infrastructure updates, fixes for urgent defects, and updates to analytic and reporting features within the NHSN application. We want, to the fullest extent that we can, to minimize the use of service packs, but as you can see from the items listed here, there are some priorities that from time to time we're going to have to take care of with a service pack. Next slide. That is it for me. I'm going to turn it over to my colleague, Dr. Barry Rhodes.
Good afternoon, everyone. So I'd like to talk to you about a whole myriad of subjects that we have, projects we have going on currently. I think many of you are aware of or using our pre-production test site. This is a site that is available on the internet that we release a couple times of a year to give you a heads up on changes that are coming. We heard some of the issues you were having with not being able to test against the application until it comes out in production. So this is our best attempt at getting you access to changes in NHSN as quickly as possible. We initially hosted that in what's called our informatics lab at CDC. And the reason for that was basically to gauge interest, to see how useful this would be. As it turns out, it seems to be very useful. And so what we will be doing in the near future is moving that off of the informatics lab to a more stable environment here at CDC, so to alleviate some of the service outages that we've been seeing. And I think it'll be a more stable environment, more robust, and give you the testing capabilities that you need. For those of you not familiar with it, it is a full instance of NHSN. It does not have our analysis capability in it, but it does allow you to import CDAs. And of course, we're talking about test data here. The test data is purged nightly, just to make sure that that nobody confuses this with a production version and sends us production data. Though a lot of the administrative and information remains, your test facilities don't get purged, but it's just the test patient data that we purge nightly. And if you're interested in that, again, send an email to us at NHSN CDA at cdc.gov, and we'll get you enrolled. Next slide, please. So this is another project we have going on. As you're all probably familiar, we host all of our value sets and business rules in a spreadsheet called the Information Data Model, or the IDM. We internally actually have issues with supporting that IDM as it's grown over time, and so we've built a capability for managing the IDM internally at CDC. We can now version it better. We can track checkouts and check-ins. we can go through an approval chain, we can version, and so forth. It also has an external component that will allow you to download the latest IDM directly from the server. You'll be able to query it for component and version, and we imagine that this will be the platform on which we continue to build out this capability. So the first phase of this will be probably live in the fall, and it will allow you to, as we said, to go in and download the IDM. Next slide, please. So a couple of other projects we have going on. We're currently prototyping a location mapping table service that would allow a vendor or third party authorized access to a facility's location mapping table. So this was something that was requested of us, and the way it will basically work is, as you know, location mappings are an integral part of the NHSN application. They're usually done when a facility is being set up for the first time, but they change over time and it needs maintenance. So you, as a CDA vendor, need access to that information, and currently you have to go to the facility admin or to the infection preventionist at that facility and get them to download that information for you, give it to you, and so forth. This is going to allow you to access it directly through a web service. It will require that the facility authorize you to do so, and so we're working on that capability. So the way it would work would be a facility would go into a page within NHSN and say, XYZ vendor can now access my location mapping tables. Once they check that box, then XYZ vendor can then will then be given user IDs and passwords necessary to access the service, and you can not only get the latest and greatest location mapping tables, but you will be able to get them by version. So if you're reporting data that's somewhat old and you need a location map that was prior to the current date, then you can go back and get those prior versions as well. We're also prototyping a synthetic data set for a pilot project of looking at what's called late onset sepsis, and we're building a service to validate results against that data set. So we're working with the VA for this to actually prototype this synthetic data set. You would import it into your system, run the algorithm for the LOS, and then be able to send those results to a service that basically grades it, tells you whether your algorithm was coded correctly and what the issues were. Again, this is just a pilot, but we're very excited about this capability and think it could be applicable to other things as well. And lastly, we're also building a FHIR Fast Healthcare Interoperability Resources interface to the IDM server, the thing we were just talking about a second ago, which would allow value sets to be retrieved as FHIR resources. And the way that might work is if you're interested in getting the latest list of organisms to report antimicrobial resistance, for example, again, a simple RESTful request to the server would allow you to download that value set and then use it as you might. Next slide. And finally, we have completed work on what we call the CSSP, the CDA Submission Support Portal. And this is a website that you can find off of the NHSN website that was developed specifically for our CDA developer community, our vendors and those folks who are building CDAs independently. And this is really a bringing together of all the information necessary to create CDAs with pointers to things like the protocols necessary and so forth. But it is really about it is its entire website devoted to really the people on this call. If you haven't checked it out, please do so. You go to the cdc.gov/NHSN website, and you see at the bottom right-hand corner there's a link to the CSSP. This is the home page of the CSSP, and you can see the various sections. There's a lot of information behind each of these links. It starts with what is a CDA, provides implementation toolkits, talks about how to import data, and there's the extensive FAQ, which we're continuously updating. All of the webinars and training videos, including this one, are posted up there now, our testing tools and so forth. So this is really a site that's for you. If you think of something that you would like to see there that you can't find or is just not available, please let us know. We're always trying to make this as user-friendly and helpful as we possibly can. The last link on the bottom right there is about meaningful use, and if you'll move to the next slide, we'll talk a little bit about that. So I think you're all probably aware at this point that antimicrobial resistance and antimicrobial use are part of meaningful use stage 3. If you go to that link in the bottom right corner that you saw a minute ago, it will take you to these pages. So currently we have a certification tool which we've put up on GitHub, and I think the link is maybe in the next slide, but that's fine. This is the tool we provided to the certification labs that will take a CDA for antimicrobial use or antimicrobial resistance. It's the R1 normative version of the implementation guide and validate it. The validation is basically just schematron validation. It uses the same technology as what you're familiar with on the Lantana website if you've gone to that validation tool. This is just a standalone version of that, essentially. And you can get the tool, as I said, on GitHub. There's a link to it you can see there. You can even download the source code if you're interested in seeing that. The meaningful use certification starts, I believe, in 2017, and there's voluntary reporting during 2017, and then full-blown meaningful use stage 3 for AUR reporting starts in 2018. And I think you've probably all many of you are involved in certification of your products, so you're probably very familiar with that process. It will be very similar to what you've done in the past for other reporting types. Next slide. And I think that's it for me. We'll now go to NHSN updates, and I'm assuming this is Mindy.
Yes, thanks, Barry.
Sure.
So the next few slides are frequent issues that we've received in the mailbox. So this first one is make sure that new users have the correct user rights to import all types of CDAs. And, so just share with your help desk and any in your IPs that help enroll new users, and make sure they have the administrator and all rights. There's also a AUR specifically CDA import user right. That would be for users who are only doing antimicrobial use or resistance CDAs, are working on, that's a part of stewardship program and so on. So there is a separation. Maybe your pharmacist would only have those rights, but in general, any of your users that work on all the CDA import types need this user right. Next slide. We are also seeing new customers coming on, which is great for you guys. So if they do not already have an OID, they will need to go enroll for one. The link is listed on our CSSP page under, I think, frequently asked questions. And if you wonder if someone does have an OID, this is the steps you can walk through to help them. So on the blue left-hand blue navigation bar, they would select facility and facility info, and there in the object identifier would be if they had an OID or not. So remember, OIDs are only required for facilities that are important CDAs. It is not needed for a CSV file, and it's not required just to enroll in NHSN. Next slide. Another reminder, only in-plan data can be uploaded via CDA. Data must also be in plan in order to be shared with CMS. However, only CMS required in-plan data are shared with CMS. So an example here is if HPRO and KPRO surgical site infection data are not sent to CMS, since there are no CMS requirements for those SSI types. Next slide. Some general updates about direct CDA automation. Presently, there are 13 vendors and approximately 2,500 facilities sending via direct. It is a batch submission process. There's no immediate reply expected. The turnaround time is based on the volume of messages within the NHSN queue at that time. We are working to improve the process, and one of the items that we are actually adding is the ability for one facility to use multiple direct addresses. That's a new scenario that has come on, so that should be in place in 2017. More vendors are beginning to pilot. If you are a new vendor who has not begun your pilot yet, we recommend you give us a call. We'll set up a meeting. We'll discuss your process, our processes, and our lessons learned. Next slide. So to move on, we will have a service pack release this summer. It's primarily an infrastructure release. It's scheduled for probably late June, early July of this year, 2016. We are sort of sneaking in our R1 normative antimicrobial use CDA as we're transitioning to our 1-year major releases. So we're bringing this on this summer, so it will be available for you as a vendor to be able to, if you want to roll up to the R1 norm AU CDA, it'll give you time to test, do your validation, and so on. You only need to move to the R1 norm if a facility is going to be doing AUR reporting for Meaningful Use 3, and I think Amy will get into a little bit more details on another slide. The service pack also includes analysis and reporting updates, fixes for our defects, and we are having a small change for our CDA import process. I think most of you are aware if duplicates are in the same zip file, the whole zip file does not import. It sort of comes back and gives you an error report. So this is going to change. Basically, the first CDA that is unique will be saved to the database. If a duplicate attempts to import and try to save to the database also, it will see that one's already there, and that one will be marked as a duplicate, and it will error. So basically your good CDA should import, and your bad/duplicate should not import, and they'll be all listed on your PDF report. Next slide. So next we'll talk about NHSN Release 8.6. So it's we're going to deploy it in December 2016. However, the changes will not be effective until January 1, 2017. I know in the past we've actually deployed it after the January 1 date, and that meant that people that did import CDAs during that little window, actually they got thrown up to the alerts. So this will stop that. High-level list of changes are we're bringing on a new CDA for the Hemovigilance Denominator. There'll be CDA updates for the Dialysis Numerator and Dialysis Denominator. We've updated the pathogen code list and the business rules accordingly. There's antimicrobial resistant updates. There will be an additional C. difficile test method code, and just in general some other business rule updates we'll get into. So first we'll talk about the hemovigilance component. So back up, yeah, there you go. We're happy to announce we do have a new CDA. It's for the Hemovigilance Denominator, and it's based on the R3D1IG. It will be available for import beginning January 1st, 2017, and it will be for 2017 data and forward. The CDA includes the data required for the Hemovigilance Denominator form, if you're familiar with the form, plus the ISBT data. So ISBT data stands for International Society for Blood Transfusion, and it's the terminology standards, or standards for the terminology, identification, coding, and labeling of medical blood products. The CDA will add granular data that is unable to be collected manually, and as I said, it includes blood products. An example of the business rule will be ISBT data will be required to be included when a specific blood products are greater than 0. And that includes for units transfused, aliquots transfused, and total discards. So next we'll take a look at the just a snippet of the form. If this is the Hemovigilance Denominator, like snippet of the form on the user interface. The CDA will include data for all the cells that are on the form in the user interface, plus the ISBT data. So as you can imagine, over here is my example. For total discards, if the answer equaled for whole blood equaled 20, then underneath that the CDA would capture the exact ISBT code for that blood product and the number, which would be 8. And then the same one, EOO, like 13, there would be 12 of them. So basically those should add up to be 20. They don't have to, because I think the ISBT codes are updated frequently, and a system may include those before we can catch up. But that's an example of how what the data that CDA will contain. The data will be displayed using NHSN's analysis and reporting function. And a webinar will be given in August that will review basically the form and the UI. We'll have the hemovigilance team on to give you details on just the protocol, the data itself, and then I'll also be on to give information on the CDA itself. Next slide. So next we'll talk about changes that affect the dialysis component. So as we mentioned before, the Dialysis Numerator CDA is moving to the R3D1IG version. So for any dialysis events with event dates equal to 2017, it must be based off that off the R3D1IG. The additional questions added to the CDA is the patient's dialyzer is reused, and the answer would equal yes or no. And conditionally required, if the IV antimicrobial start equals yes, was this a new outpatient start or a continuation of an inpatient course? and then your answer would be the new or continuation. As probably you already know, these were already in the user interface and they were optional, and now they will become required or conditionally required even for manual entry. Next slide. So the dialysis denominator, this is the first time we've actually moved this to a new version. So it also will be based off the R3D1 version of the IG, and it will be for any dialysis denominators for the dates greater than or equal to 2017 must switch to this new version. And the additional field is number of these patients for whom dialyzers are reused. Next slide. We have a big change, the pathogen codes updates. I will get into a little deeper in a few slides in the patient safety component, but just be aware for any dialysis folks that you will need to look at that new pathogen code tab in the IDM when you get it. Also affected is unusual susceptibility alerts have been added to the dialysis component. If you're familiar with patient safety, it is just like it'll work just like it does there. And so basically the rule is it'll have alerts in the user interface for specific combination of a drug susceptibility against an unusual pathogen will be required to be manually confirmed or corrected by a user. CDA will import, but the user will need to view in the alerts in the user interface. And I have a few screenshots here, so if you're on the blue navigation bar, you would go to alerts, and then it would take you to the next screen, and you would select whichever alert you want to, which this one would be unusual susceptibility profiles, highlighted in yellow. And then actually I'm missing a jumped a step, but you would select on the specific event number, and then it would take you to this USP alert page, and basically the user will have to confirm, press cancel, and go back and correct the susceptibility, or say OK or cancel to exit. Next slide. Another new change is the 21-day rule for dialysis events. So it used to be an alert, and now it's going to be for a more of a hard stop. So it's changing from an alert to unable to manually enter or import for equal to or greater than 2017 data. Validation is on patient location and event type, and it includes the IV antimicrobial start, positive blood culture, or pus redness or increased swelling. An error message will be displayed if the combination is less than 21 days from the same patient, location, and event combination. So for CDA import, you will get this error message displayed on your PDF report. So for the next one, a new question's coming along for the event. Was a blood sample collected for culture? It will be added under IV antimicrobial start on the dialysis event form. Presently, even in the UI, it'll be conditionally optional. And with that, there will be a new CDA coming on, and it'll be based on the R3D2 IG, and that will be a valid import for a year later, which is January 2018. Next slide. So next we'll get into the patient safety changes. This is a big one. I think we all went through this a few years back, and we've updated the pathogen code list. There's been an addition of approximately 1,000 pathogens. We've updated the pathogen names and updated the business rules accordingly. This also affects the MDRO definitions and the unusual susceptibility alerts. The events affected are antimicrobial resistance, BSI, UTI, SSI, Lab ID, Dialysis, and I know y'all work on non-CDA events like pneumonia, VAE, and so on. So just so you're aware that it rolls over to those two. Next slide. I'm going to cover quite, like 2 or 3 pathogen-related changes that are coming, and then I'll show you a brief view of the IDM to sort of bring it all together. So one of the changes is Salmonella species no longer reported for BSI, LCBI, or BSI MBI. So we've actually added a new column named LCBI pathogens to the IDM on the pathogens code tab. So, and it'll have an X in there for the pathogens that are allowed to be reported. And along with this, the MBI pathogens has, that column has also been updated. Next slide. Also, select fungi are no longer reported for events in the patient safety and the long-term care facility components. It includes blastomyces, histo, cocci, para, crypto, pneumo. So a column has also been added to the pathogens code tab, and it's labeled PS and LTCF component organisms. And it also, we have X for the allowed organisms to be reported. And just as you know, there's no CDA imports for the long-term care facility component yet. Next slide. So here's a snippet of the IDM. So additional columns that have been added. So you'll see column J is our PS and LTCF component organism. And then column M is our LCBI pathogen, pathogens allowed. Also, column Z is where is the new list for the SNOMED CT codes that you want to use beginning for 2000 for the release 8.6 beginning in January 2017. And then in column AC, you see we've added notes. We really tried to add whether it was just an update, whether it actually was added, whether or not this organism is now inactive, and so on, to try to help as you go through, you know, updating your code also. There is also another column we've added, which was the next column over, with a note that says we've added some pathogens that included an antibiotic susceptibility description, whether it's resistant to carbapenem or things like that. So in doing that and looking at the NHSN protocol, the SMEs requested that those organisms be rolled up to the main pathogen without the drug description or susceptibility description. So when you'll see it, you know, usually you have like, example, 4 synonyms that all roll up. They all have the same SNOMED code, so you don't have to worry about it. And though in the user interface, they'll all say Staph aureus or something. Well, this time that will have Staph aureus methicillin resistant actually has a different SNOMED code, and then it will actually be rolled up in the application to Staph aureus. So just so I want you to know, be aware of this, because your users may say, I imported Staph, you know, methicillin resistant Staph aureus, but in the user interface it says Staph aureus. And so that is noted on this spreadsheet, just so you're aware of that. Next slide. So the R2D2.1 lab ID that you're presently submitting is not changing. We're just letting you know that in the user interface, the following questions below the last physical overnight location and has this has patient been discharged from your facility in 4 weeks or from another facility in 4 weeks, those are all becoming optional. We got user feedback, and those were very difficult to find the correct answer appropriately or correctly, so those are becoming optional. However, in your CDA, they are required, but you can, as you already knew, you can use the null flavor equals NA or unknown per the IG specifications. So just so you're aware of that. Next slide. No effect for CDA really, just want you to be aware. The description of 11 codes have been modified to include culture and non-culture based microbiologic testing method for clinical diagnosis and treatment. This is referred to in the protocol, so you'll see it on the user interface. The descriptions have changed a little bit. Your CDA codes are remaining the same. But just so you are aware, and there's some examples where they took out the word culture and made it just a little bit more generic. Next slide. So for a business rule change, a SSI business rule change, for event types for SSI or GI and specific criteria equals GIT or IAB, a business rule is being updated, so you must include at least one of the organisms identified from a blood specimen must be an MBI pathogen. And you know that's on the, has its own column in the IDM. And this business rule will also be updated on the specific criteria BR tab. Next slide. We've added an additional C. difficile test method, and this test method is associated with your MDRO monthly denominator CDA, and it's begin in 2017 data. There's the code, is NAAT plus EIA if NAT positive. So make sure you include this in your value set NHSN CDA test method that you already use for the R2D21 MDRO summary CDAs. And I know some people also, it's also referred to as the POM, P-O-M. All right, next slide. So as a recap, we really only have 2 backward compatibility deadlines, and it is the dialysis numerator and the dialysis denominator. So make sure you transition to those 2 CDA versions beginning in 2017 data. And I think that's it, and I'm going to pass it on to Amy.
Thanks, Mindy. So a couple last changes to the patient safety component for Release 8.6. We will be setting the retired ASC or ambulatory surgery center locations to inactive. So within the last release, these 3 locations were no longer allowed to be added to facilities as new locations. So in 8.6, we'll be going back into NHSN, and any facility that still has these locations mapped in their facility, we will be setting them to inactive. Additionally, data will not be able to be entered into these 3 location types as of January 1st, 2017. And then lastly, we will be adding a business rule for the patient Medicare number validation. So the patient's Medicare number must have either 7 to 12 alpha or numeric characters, and no special characters are allowed. So if A and B are not met, NHSN will generate a warning message that you'll see here on the bottom of the screen in the screenshot. The warning message will not be generated during either CDA or CSV import, however. Alrighty, so now moving on to some antimicrobial use and resistance module updates. For the AU option, or antimicrobial use option, we will be making no changes to the data collection protocol for 2016 and 2017. However, we will be adding some new analysis output options in January of 2017. These do not affect your CDAs. However, for your customers, they will be able to view their SARs, their standardized antimicrobial administration ratios, per month. And we'll also be adding some new visualization for the SARs. We did want to remind you to promote your own submission of data into the NHSN AU option via the SIDP AU vendor list. I've included the link here on this slide. If you have successfully submitted AU data with one of your clients or are working towards or interested in doing so, please reach out to the SIDP list to get your name added to that list. We do refer facilities to that list when they ask us which vendors have the capability of sending AU or are interested in developing AU submission to NHSN. Also, please let us know if and when you've successfully implemented AU submission with your first client facility. We are keeping a running list, and it's good for us to kind of keep an update of that internally. As Barry and Mindy highlighted, we will accept the R1 norm AU CDA as of the 854 release coming this summer. Just a reminder that the data using the R6 or the R1 norm are exactly the same. R6 will continue to be a valid submission for the foreseeable future. However, you must use the R1 norm to meet the Meaningful Use 3 standards. Moving on to the antimicrobial resistance option, or AR option, we have made a bunch of clarifications to the AR option protocol. There are no changes to the AR option CDAs. However, we did make a lot of clarifications and add some helpful examples to the AR option protocol. We've posted that recent update about a month or so ago, so if you have not taken a look at that new protocol, please do so. We also have the new AR option toolkits available on the vendor website, as you can see on the screenshot on this slide. And we are working on adding additional guidance documents, such as helpful hints and some AR option specific slides in the next few months to those toolkits. We are making one change to the AR option in 854, and that is fixing a defect that was identified. Currently, some of the AR data that has been imported was missing the MIC values, and the validation was a little loose on import. So we'll be fixing that and tightening up the validation of the required fields for the CDA import. For 8.6, as Mindy mentioned, we are making some clarifications rather, to the AR option. This first change involves specimen SNOMED codes. We will be updating the specimen list that is accepted for the AR option to include specific child codes. So right now, the screenshot on the left shows the currently accepted SNOMED codes. The screenshot on the right shows all of the additional child SNOMED codes that will be accepted in 8.6. So right now, we ask the vendors to do the roll-up and report them all, for example, under blood specimen. But for 8.6, you'll be able to report the parent blood specimen code or any of the child blood specimen codes as outlined in the IDM, and NHSN will do that roll-up on the back end. Additionally, we have updated the AR option pathogen code list. As of right now, the vendor has to do the roll-up on their end. So for example, on this screenshot for Acinetobacter, as you know, there are many types of Acinetobacters that can be identified by the lab. At this time, the vendor does the roll-up and reports them all under the Acinetobacter SNOMED code shown in column D. However, for 8.6, NHSN will be updated to allow the specific SNOMED code shown in column F to be reported, and NHSN will again do that roll-up on the back end. And for the AR option in 8.6, we will add the ability to report specimens collected in outpatient locations. However, just 3 select outpatient locations at this time. So facilities will be able to submit specimens collected in outpatient locations that are mapped in NHSN as emergency departments, pediatric emergency departments, or 24-hour observation units. Alrighty, and last but not least, the future CDAs that are under development at this time. As Mindy mentioned earlier, we will be updating the dialysis numerator CDA in 2018. And per popular request, we are working on getting together the ventilator-associated event CDA. That is currently estimated for January 2019 release, as well as a late onset neonatal sepsis CDA, also planned currently for January of 2019. And just a few last reminders before we close out today's webinar. We will continue to distribute the draft IDMs via email until the web-based interface IDM is available. As always, we always welcome feedback from vendors. If you have feedback from yourselves or from your clients, we would love to hear that. And we're always open to having individual vendor webinars. If you're struggling with a specific type of NHSN reporting, or you have questions that would be better answered via webinar instead of email, please let us know and we'd be happy to set those up. Alrighty, so now we are